Hey everyone, we are in the Silver Hill Grand Rounds program. Welcome to you all as you join, and we'll get started in a moment, just as soon as people start populating. All right, welcome everybody. Thank you for being here. I'm Jeff Katzman, the Director of Education here at Silver Hill Hospital, and we are absolutely delighted to have you join us, where we are honored, privileged to welcome back, by popular demand, Dr. Brent Forrester, presenting on the topic of evaluation and management of late life depression and older adult bipolar disorder. I'll have the pleasure of introducing him in just a moment, but first a little bit of housekeeping details. Our next Grand Rounds is on November 13th, when we also welcome back, by popular demand, Silver Hill Hospital's own Dr. Emily Haas, director of our Triumph program, who will present to us calming flashbacks and frenzy, de-escalation of post-traumatic and dissociative crises. Back to today's lecture. Your questions remain an important part of our Grand Rounds. I will moderate a Q&A discussion with Dr. Forrester at the end of his lecture. This is a great opportunity to put forward questions and comments to Dr. Forrester, which you can submit anytime during the lecture by using the Q&A link. If you'd like CME or CEU credits today, please complete the evaluation survey that will automatically show in your browser when we end the webinar. We will also email a copy of the survey to today's participants. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest. And now it is my great pleasure and honor to introduce our guest speaker today, Dr. Brent Forrester. Dr. Forrester is the Dr. Francis S. Arkin Professor and Chair of Psychiatry at Tufts University School of Medicine, Psychiatrist in Chief and Chairman of the Department of Psychiatry at Tufts Medical Center, and Director of Behavioral Health for Tufts Medicine. He spent a quarter of a century of his professional career at McLean Hospital and Mass General Brigham, where he served as the Chief of the Division of Geriatric Psychiatry at McLean Hospital and Senior Medical Director for Value-Based Care Solutions in the Population Health Management Department at Mass General Brigham. Dr. Forrester is an expert in geriatric psychiatry, specializing in the treatment of older adults with depression, bipolar disorder, and behavioral complications of Alzheimer's disease and related dementias. He's a past president of the American Association of Geriatric Psychiatry, a distinguished fellow of the American Psychiatric Association, and has previously served on the board of directors of the Alzheimer's Association of Massachusetts, New Hampshire, and chair of their medical scientific committee. Dr. Forrester's research focuses on novel treatment approaches to manage the disabling behavioral complications of dementia, such as agitation and aggression. His work also includes the implementation and evaluation of collaborative care models for comprehensive dementia care with primary care medical settings. So with that, Dr. Forrester, welcome. Thank you again for agreeing to come back and teach us some more. Just really appreciate it. And it's so good to see you. I'm going to turn my video off here, and I'll be back with Q&A. And if people have questions along the way, please put them in the Q&A, and we'll get to those.
Wonderful. Thank you, Dr. Katzman, and thank you to the Silver Hill community for inviting me back. It's a pleasure to be here today. As Dr. Katzman mentioned, geriatric psychiatry has been my passion for my career, which is just about 30 years in length. Here are my disclosures. And I was asked to talk about mood disorders in older adults today. And so we're gonna focus on ways to identify and differentiate the clinical features of late life depression and bipolar disorder in older adults. I'll present a few cases and also go through diagnostic criteria. And my focus in terms of treatment interventions will be mostly pharmacotherapy, evidence-based interventions. I will mention some of the psychotherapeutic approaches as well and how they're utilized. I also want to make the point, and one of the take-home messages here is really understanding the difference between bipolar disorder and depression when they present in younger adults for the first time, and now the patient in their 70s has lived with this illness for 40 years versus people who develop mood disorders for the first time over the age of 60, 65, et cetera. So early versus late onset is a distinction I want people to think about as we go through this talk. And then I'll talk a little bit about current and future research opportunities. So I always start geriatric lectures about psychiatric care when focusing on pharmacotherapy with some basic principles of geriatric psychopharmacology. And I think it's really important because older adults often present with a lot of confusing symptoms. The symptoms are overlapping, they're heterogeneous, and oftentimes it's easy to get lost and to throw medicine to people in the midst of a crisis without a plan. So always have a plan, and that plan starts with at least a guess on what the diagnosis is. I know it sounds basic, but it's easy to get lost. The second is, oftentimes we'll see improvement in patients' outcomes by taking away medicines as opposed to starting them. And that's because of drug-drug interactions or side effects of the medication. It's also really important that we understand the principle of starting low at doses that are low and raising the dose slowly, but we often need to push the dose to higher levels, and maybe even the same levels as younger people. It just takes longer to get there safely. And no matter what we do with pharmacotherapy in older adults with mood disorders, we know that psychotherapy and behavioral interventions will always augment our treatment response, and that the combination therapies are always more effective than either one alone. All right, so next slide. Here we go. All right, so first with depression. One thing I want to impress upon all of you is that depression in older adults, broadly depression in older adults, is common. But it's not the major depressive disorder in the DSM-5 that's the most common form of depression in older adults. It's often minor depression or subsyndromal depression. They don't fully meet the DSM criteria, but they cause, the symptoms cause functional impairment. But if you were to walk into any primary care practice right now in the United States and looked at people in a waiting room 65 and above, about 1 in 6 of them would have a clinically significant depressive condition. One thing we need to remember is that getting depressed with advancing age is not to be expected. It's not a normal fact of aging. And we've got to be really careful about an ageism bias when we're talking about any mental health issue in older adults. And I often feel that people with mental health challenges in older adults are duly stigmatized by the issues of mental illness as well as aging and ageism. And when we basically project our own feelings about getting older because of experiences we've had in our professional or personal lives on the patients that we're treating, it leads to problems with accurate diagnosis and treatment. It could lead to therapeutic nihilism, like why bother? I'd feel that way too. So we have to be really careful about the ageism bias. But we know that depression, not only in younger adults, but especially in older adults, is associated with functional impairment and higher risk of suicide. We know that depression alters the risk and the course of numerous general medical conditions, including cardiovascular disease, diabetes, et cetera. We know that side effects to medications will directly impact someone's adherence with treatment. And when we see depression in older adults, it's rarely a one-time event like it often can be in younger adults. It's often a recurrent chronic illness, and it needs to be managed and thought of in that way. We'll talk more about a lot of these points in more detail. So why do older people get depressed? You'll notice that family history and genetics are not here. It doesn't mean that they're not relevant, but if older people develop depression for the first time in later life, it's usually not a genetic disorder. It's usually due to some other problem, like a medical illness. So we see depression at higher rates in older people of medical comorbidities. So the rates of depression in primary care, in long-term care, skilled nursing facilities, or long-term care assisted living facilities, much higher than the general population. We also see that people who perceive themselves to be of poor health and disability, again, subjective experience, are more likely to have depression than those who may be more optimistic and have a different outlook. We know that there's a bidirectional relationship between pain and depression. We know that people with pain syndromes are more likely to have depression. And we know that people with depression are more likely to experience pain at higher degrees. And finally, we know that the use of certain pain medicines, particularly the opiate analgesic medications and some others, directly impact not just cognition, which we know about, but also mood in a bad way. There's also a very important and complex relationship between depression and dementia. And we talked about this in my last talk, but basically, people with a lifelong history of depression from the ages of 20s and above, regardless of treatment, and maybe treatment helps, but definitely a history of depression, increases your risk of getting Alzheimer's disease when you get older. Now, people with dementia who never had depression before may develop depression for the first time in the setting of dementia. About 40 to 50% of people with dementia get depression in the setting of that illness, even if they never had it before. So again, a lot of different ways in which depression and dementia are related to them. Alcohol use, opiate use disorders, and benzodiazepine use disorders. These are the common use disorders of the current cohort of older adults, but that's rapidly changing with the baby boomers that are quickly filling the 65 and above age range. And we're seeing different types of drugs of abuse, but we know that misuse of substances, whether they're prescription or drugs or alcohol, will impact the risk for depression. Below those top 4 or 5 are 3 what I would call psychosocial stressors associated with and maybe causative of depression in later life as well. So there are financial difficulties, there's loss and bereavement, and the losses could be actual loss of loved ones. It could also be loss of one's identity because they retired, or the loss of close friends and social network. And then, of course, social isolation, which is getting more press since the pandemic, and the impact of isolation on the risk factor, by the way, not just for depression, but also independently, potentially for dementia. I mentioned this already, but in more detail, people with the medical situations on the left column, patient populations, are at high risk of morbidity and mortality when there's comorbid depression. So for example, as an example, people who've had an MI, a heart attack, a myocardial infarction with depression over the next year are more likely to be dead in a year than those who didn't have depression along with their MI. People who enter a nursing home with depression are more likely to be deceased a year later than those who enter a nursing home without depression. And I could go through all sorts of reasons why that may be, psychologically, socially, and biologically, but this is more of a demographics and a risk factor slide for bad outcomes. Depression, when mixed with other medical comorbidities, leads to poor outcomes. And I'm saying all of this because it just increases the importance of adequate treatment, which we'll talk a lot about. Some people with depression in later life, as I mentioned before, it's not a one-time illness, it's a chronic recurrent illness. And so there are psychosocial factors and biological factors that predict or contribute to a chronic and relapsing course of illness in older adults with depression. The psychosocial factors you can see here, including bereavement, dependency needs, interpersonal conflicts, and changes in roles, as I mentioned. By the way, the role transition, one common role transition is retirement. Another role transition is somebody 65 taking care of their much older parent and now being feeling like there's been a role reversal between the parent and the child. This comes up a lot. Now, all of those psychosocial factors respond really well to psychotherapy, and especially interpersonal therapy, IPT, CBT, especially when there's comorbid anxiety and sleep disturbance. So there's a lot of psychotherapeutic approaches to specifically target some of these factors. And then there's the progression, sometimes a depletion of psychosocial and economic resources as well that may contribute. But the four on the bottom, 3 of which are biological, and one is an access issue that I just want to highlight. People with depression and sleep disturbance, or cerebrovascular disease, stroke, or neurodegenerative illness like Alzheimer's disease. When you see depression with those 3, it's harder to treat. It takes longer to treat. It may not be as adequate treatment response. It may take longer to respond, and you may need to use augmentation strategies and certainly combination therapy with psychotherapy. And then finally, access. Those of us in the Northeast, especially where I am in Massachusetts, have a remarkable, relatively high number of geriatric mental health clinicians for a population. But there are deserts of geriatric mental health specialty care most everywhere in our country, and not to mention around the world. There are just so few people going into our field. So access to treatment with specialists is limited. But that doesn't mean, hopefully the vast majority of those of you on here are generalists in the mental health world and see adults, but now will hopefully feel more comfortable taking care of older adults, because if we don't do that, there's no way we're going to adequately address the needs of this aging population. So I'm going to go through for those of you who do prescribing or follow older adults, it's really important to pay attention to medications all the time. And then I'm just going to go through some of the evidence base of the psychotropic drug classes for depression. So the older drugs, the tricyclic antidepressants that were sort of the norm when I was in training, and then where the SSRIs were just being introduced, these medications work well for depression, but they're extraordinarily toxic from a side effect perspective. Nortriptyline may be the most widely used in older adults because it has a known blood level where there's therapeutic efficacy, above which there's more toxicity, and below which there's lack of efficacy, is a drug that also has less anticholinergic side effects, like dry mouth and constipation, blurry vision, than amitriptyline and imipramine. The other problems with these medications beyond anticholinergic include orthostasis. These drugs block the alpha receptors, leading to dizziness with standing, and a drop in blood pressure can be quite dangerous, and can also lead to a change in cardiac conduction that could predispose people to arrhythmias. And that's why these medications are so lethal in overdoses, because of the propensity for leading to cardiac arrhythmia and death. Of course, magnified in older adults who may have underlying cardiovascular disease. When fluoxetine came out in 1988, it really changed our treatment of depression. I mean, we sort of take all these for granted now because they've been around for so long. But prior to 1988, primary care doctors didn't want to prescribe the tricyclics. They were dangerous for older adults. There was a lot of undertreatment in particular. So now there's adequate treatment. And I would say of these, and I'm not going to go into them in full depth here just because there's a lot to cover today, but the ones that have been best studied in older adults, I would say, are sertraline, citalopram, and escitalopram. These three are essentially about a day-long half-life. Their drug interactions are modest, not something you often worry about. And they're generally well tolerated, and they have great safety data in older adults with depression, including the well-known SAD-HART, that's a great acronym, SAD-HART study that looked at the use of sertraline for patients with cardiovascular disease. And the primary outcome measure was not depression. The primary outcome measure was cardiovascular adverse events like arrhythmia or MI, etc. I would avoid paroxetine because it's highly anticholinergic. So it's like giving somebody Benadryl or, an anticholinergic antihistamine. Fluoxetine, although it's approved for late life depression, has a very, very long half-life. So if people, for whatever reason, have tolerability issues, you're going to, at some point, run into problems because you're going to then have to stop the drug, and it's going to, be in your, it's going to take about 5 to 6 weeks to get out of your system. The other thing I'll just say about one other peculiarity with citalopram is this warning that came out now 13 years ago. It causes QTC, the QTC interval on the EKG prolongation, which can be associated with cardiac arrhythmia and sudden cardiac death. And so in older adults, although the younger adult warning is don't use citalopram 40 milligrams or more, here it's above 20 in older adults where we have to be cautious. So the SNRIs came out over 20 years ago now, duloxetine and venlafaxine. These medications are active on both serotonergic and noradrenergic neurotransmission. What's nice about duloxetine compared to venlafaxine for older adults is that the drug is a dual-acting reuptake inhibitor, both serotonin and norepinephrine, at the starting dose, which is 30, or in this case, this one study here, which was published many years ago, 60 milligram a day dose. Whereas venlafaxine, you got to go up to a higher dose before you get this dual-acting effect. The study I was referring to looked at duloxetine for a cognitive composite outcome in late life depression, as well as mood. And I was involved in this study back in the early 2000s. And interesting, even though we often start people at 30 milligrams a day, 60 milligrams a day was the starting dose. It was well tolerated, and there was no dose adjustment up. The higher dose range on duloxetine, even in older adults, could be 120 milligrams a day, but I would be very cautious on blood pressure escalation, risks. When I started my clinical practice in Manchester, New Hampshire, I'm dating myself now, in 1997, this drug had just come on the market called mirtazapine, and I inherited a caseload of patients from turned out to be a very insightful colleague of mine. A number of them were on mirtazapine and couldn't for the life of me figure out why you would use this new drug when we had all these great SSRIs in older adults with depression. And as I started to see how well these patients were doing, and I started to learn about the pharmacological profile of mirtazapine and use it over the years, I realized it has an amazing niche in older adults, but only a particular population of older adults with depression. If you see somebody who's older with anxiety, who's not sleeping well, whose appetite is poor, who's got a lot of somatic, older adults with anxiety and depression often don't say they're sad or depressed. They say they're worried, they're not sleeping, and my stomach's bothering. Those are the patients who do beautifully with mirtazapine. 15 milligrams at night to start with, up to 30 to 45 milligrams at night. It's more sedating. There's more of an antihistaminic effect at the lower dose. Now, there is some anticholinergic effect with mirtazapine, but it's not like giving someone an antihistamine like Benadryl. It's much less. It's also a great anxiolytic drug, in part because of its antihistaminic effect, but also, when you give people SSRIs, you're basically stimulating all the postsynaptic receptors. Some of those postsynaptic receptors increase anxiety, like the 5-HT2 receptor. Some of them increase GI distress, like the 5-HT3 receptor, and some increase sexual side effects, like the 5-HT2 receptor as well. What this drug does is it not only increases serotonin and norepinephrine, but it blocks the postsynaptic 5-HT2 and 5-HT3 receptors, which basically blocks the anxiogenic effect of serotonergic drugs, and it blocks the sexual side effects of serotonergic drugs, and it blocks the GI side effects. And not only does it block the GI side effects, but the 5-HT3 postsynaptic blockade is the same mechanism of action of drugs used to treat nausea and vomiting in people getting chemotherapy, ondansetron or Zofran. Same mechanism. So if you've got an older adult who's anxious, not sleeping, depressed, and has GI complaints, this drug works extremely well and relatively quickly. Now, the antidepressant effect truly takes 4 to 6 weeks, if not longer, in older adults. And weight gain and sedation, even, we know it's a problem in younger adults. It's also a problem in older adults. So we have to be careful about that. And then I'll just say about the study that I listed down here, which is remarkably now almost 15 years ago, it really for the first time showed that when you combine SSRIs with mirtazapine, or SNRIs or bupropion with mirtazapine, you achieve greater remission rates after 6 weeks than versus using the fluoxetine SSRI alone. Big difference, like twofold increase, response rates. Now, this was not an older adult sample, and it's never been replicated in older adults. But if I had to bet, I bet you'd see the same thing. We also found in that study, they found that if you discontinue one of those agents, whichever, not mirtazapine or SSRI, either one, patients relapse often, 40% of the time. So the combination therapy often works well. I would not recommend starting people on combination therapy, but it's a rational augmentation strategy for people with residual anxiety, depression, poor sleep, if they've been on an SSRI for 4 to 6 weeks at therapeutic doses and they're not doing that. My colleague, Eric Lenz, is the chair of psychiatry at Washington St. Louis, published a study just last year in the New England Journal of Medicine, and it was a really great trial because it was trying to understand how to make rational pharmacotherapy decisions for older adults with depression. What's most effective? What's best tolerated? It was a head-to-head trial. Of course, they weren't comparing every drug, but they had a very interesting study design. So they took a population of patients who were 619 patients. They were all age 60 and above. They all had major depressive disorder, and they had documented non-response to 2 or more antidepressant trials. Then they were randomized to one of 3 groups. In green, they either got augmentation of the current medication, like SSRI, with aripiprazole, or with bupropion, or instead of that, they switched the SSRI to bupropion. And so, very interesting. I can't see a show of hands here, and I'm not going to bother, but I'm curious what people think. Which does better? And that was their question. Was there a better response rate, remission rate, which is resolution of symptoms and improvement in functioning, and change in the MADRS, which is the outcome? So it turns out that the augmentation, both approaches, beat switching. You can see that, again, the remission rates weren't great, and that's not surprising. Response rates usually are 40 to 60%. Remission rates usually are 25 to 35%. But here, it was the add-on of aripiprazole or the add-on of bupropion that was more effective than the switch to bupropion. So both the magnitude of antidepressant effect on the MADRS, as well as the overall remission rate, which is resolution of symptoms. And I didn't show it here, but the tolerability was equivalent. So we didn't see more, they didn't see more falls or other adverse effects in the augmentation groups or versus the switching. Now, what about psychostimulants, Ritalin, methylphenidate, or Adderall, long-acting stimulants? Although there were use, in some ways remains controversial only because there's minimal research in this area and there's a lot of use and there's a risk of, the liability for, use and dependence is there. You get a rapid effect. And so you'll know in a short period of time for a patient who's depressed with apathy, with lack of motivation, with psychomotor slowing, adding on methylphenidate at 5 milligrams a day to start with and after week 5 BID, and maybe going as high as, but no more than 10 BID, it may be effective. And some patients I've had for years did well with combination therapy. It's especially helpful in patients with current medical illness, who don't tolerate other antidepressants, who need a more rapid response, and the effect can actually be lasting. And some people wind up not abusing these drugs, and they wind up on them for quite a while. There's research now, I'm not going to talk about depression and dementia treatments, but there's now an increasing literature for apathy and dementia, and stimulants seem to have an effect. One of the trials called ADMET, Alzheimer's disease plus methylphenidate trial, was positive, and there's a new grant that we're part of that we're submitting today, which is going to use we're going to take those findings and expand them with more of a longitudinal effect. Again, it's for apathy and dementia, not for depression. So for those of you who don't do late life depression work, you may not have heard of this syndrome, which some people call the vascular depression syndrome. Some people call it the depression executive dysfunction syndrome. The reason I want to highlight it is because you see these patients all the time and you may not know it. So the sort of the signature clinical profile would be somebody who's 75-year-old male, got extensive vascular risk factors, high blood pressure, diabetes, and hyperlipidemia. They're on a statin, they're on an oral hypoglycemic medication, and they're on an antihypertensive drug. And their family is really upset because their loved one sits around all day long and does nothing and doesn't seem to want to do anything. And when you test them, they don't sound sad and crying and hopeless, but they sound kind of blah and apathetic and amotivated, and the family's really frustrated. And when you test their memory and their cognitive functioning, their memory's pretty good. And if they have memory problems, it's not a storage problem. They can recall the words with prompting, but they've got pretty substantial executive dysfunction, organization, planning, decision-making, initiation of new activities, and so forth. It's important to recognize this group of patients because they may have what we call a vascular depression or a depression executive dysfunction syndrome related to microvascular ischemic changes in the brain disrupting frontal and subcortical circuitry. My colleague, Dr. George Alexopoulos, spent his career at Cornell in New York, really invented this term along with colleagues of his at Duke back in the late 90s, early 2000s. Really in the early to mid 90s, I should say, and then really expanded upon that through the 2000s with a number of treatment interventions. But this is a syndrome which remains a theory to this date. It's a syndrome that you don't see in the DSM, but it's a true clinical syndrome that does, it's really important to recognize because people are harder to, first of all, the diagnosis is confusing. Second of all, the response to treatment is not as robust to those patients without cerebrovascular disease. The risk of relapse is higher, there's more likely to be recurrence. And even after people respond, they often have a fluctuating symptoms. So people who have these white matter changes, which I'll show you in a minute on their MRI scans, often will predict this syndrome, executive dysfunction syndrome, and poor treatment response, but it's not a universal finding. So if you look at the Marty Goldstein, thanks to you, MRI scans from a patient, you see around the ventricles, you see the periventricular white matter hyperintensities here. And you see some lacunar infarcts as well in the cortex, maybe disrupting these circuits. This is when we talk about white matter hyperintensities, there's both periventricular and there's also these punctate lesions, these white matter lacunar infarcts. Some people used to call this Binswanger's disease, but this clinical syndrome is we refer to as vascular depression or depression executive dysfunction syndrome. The reason why it's important to recognize is because it's treatable, just takes longer, and you often have to use dopaminergic drugs as well, like a Wellbutrin augmentation or a stimulant or maybe an SNRI versus an SSRI. SSRIs, generally speaking, and this is just my own clinical opinion, not based on a lot of data, probably not as effective as SNRIs or dopaminergic drugs with SSRIs or stimulants. I'm not going to spend a lot of time on ECT or ketamine or TMS, but I do want to mention ECT quickly. ECT is a dramatic potentially life-saving intervention for older adults with depression. The population that responds best to ECT for depression are older adults with depression and psychotic features, or older adults with depression and catatonia. Really amazingly effective responses and truly life-saving responses, because 3-4 days without eating and drinking in older adults does lead to risk for not just malnutrition, but also cardiac abnormalities and so forth. So it can be really quickly, dehydration can be really quickly medically challenging. So think of these patients with refractory depression, especially with psychosis, not eating suicidal as a great treatment option. And what I think happens often, especially when ECT is not readily available, or say you're in a standalone psychiatric facility versus embedded in a general hospital facility, we try everything else before ECT. And then when we get to ECT and the families finally agree and the patient agrees, we wonder, why did we wait so long? So it is highly underutilized for many reasons. Some of it's availability, some of it's stigma. I'm not going to say much about ketamine, but to me, this is an area that is worth great exploration. I worry about the use of ketamine in older adults without a lot of research yet, but there may be a role. And TMS is likely effective in older adults with depression. And my colleagues at Emory and in New York and Sacred Hillside have done some work in this area. But to me, both ketamine and TMS really require, more investigation in older adults. The other area that's being explored now is this transcranial, so TDCS, direct current stimulation, which can be administered with a home device and is being explored now for both late-life depression and for depression and dementia. So I would just say that the whole world of neuromodulation, as you know, is exploding, especially with psychedelics and neuromodulatory pharmacological interventions. But I also think some of these procedural interventions like TMS and TDCS are also getting more traction, and we just need to see more research, frankly, in older adults. I'm not going to dwell on this, but the other take-home message I just want you all to, think about. I'm not going to give you my whole pop health talk now, but I want you to understand what collaborative care is and what it is not. Collaborative care is not psychotherapy. Collaborative care is not pharmacotherapy. Collaborative care is not coaching. It is all of that. All of that in a team-based approach connected to or embedded with a primary care or even specialty care medical setting. You could even do collaborative care in an outpatient psychiatry setting, but that would actually take time away from your clinicians to take care of more complex patients. The reason why collaborative care is so well regarded in our field is because there have been nearly 100 studies demonstrating clinical outcomes that are effective, with 12-month depression response rates being twice as much as usual care. So the way these studies, the original IMPACT trial that Jürgen Unitzer did and colleagues at the University of Washington, this study was in older adults. People don't know that, but the original intervention of collaborative care was the IMPACT trial in older adults. And that's where the remission rates were, the response rates, 50% reduction, were twice as much. Now, of course, we're getting 50% or less response rates. We have a lot more work we need to do here, but this was the original IMPACT trial, older adults 65 and above. So not only do you have better clinical response, but you get better cost savings. You spend less money on these folks than usual care. And 8 years later, for an intervention that lasted 1 year, you see an improvement in outcomes, including physical functioning, decreased pain, and a reduction in suicidal ideation. So what collaborative care is pairing a behavioral health support specialist, non-clinician, along with a supervising psychiatrist. Often there'll be a social worker in the mix there, because some of the people referred to the team will need more care, and they'll have to be stepped to a higher level of care. Some people will go through the collaborative care intervention where we do a measurement-based care following PHQ-9s, GAD-7s, and getting people to response and remission, and they'll need more than a coach doing behavioral activation, motivational interviewing. In some cases, they're doing short-term CBT-like interventions. But if you look at this from a remission standpoint, in this other study that was done a number of years ago, the median time to remission in patients getting collaborative care is about 3 months versus usual care, which is the PCP decides what they want to do, they refer them out, they treat them with medication. It takes almost 2 years. We don't have that time to wait for all the reasons you understand. So just in conclusion of the first part of the talk, it was a quick run through of late life depression, but hopefully you got something out of this. Here are some principles about management. I'd like you to think about treating people all the way to remission. That means not just 50% reduction in symptoms, but return to functional capacity, whether it's social relationships, work, other aspects of functioning. In psychiatry, if we're going to measure anything, we usually measure symptoms. In older adults, I would argue one of the first things I ever learned in my field, in my fellowship, was measure functional outcomes. I mean, it sounds so obvious, right? But do we do that in our clinical practice? Not well. We talk about it, we ask about it, but we don't have objective outcome measures. We need to look at social interaction, meaningful, sort of quality of life measures, and also physical functioning and occupational functioning. Now, if people are partially responding to treatment within 6 weeks or at 6 weeks, then they'll probably get fully better by 12 weeks. And we should stay the course with their pharmacotherapy regimen. Now, I say that, but if someone's partially responsive and they're still not sleeping well and they're anxious and agitated, you're going to want to do something different than increasing the dose. You should increase the dose, maximize the dose. But the question is, do you switch or do you augment? And based on Dr. Lenz's study that I showed you, that trial, it looks like augmentation may be preferential to switching. And Dr. Chip Reynolds, who was Dr. Lenz's mentor, who basically wrote this about 15, almost 20 years ago now, he said switching is as effective as augmentation. That was before the Optimums trial that his mentee just led. So I would say you may want to consider augmenting before you switch. But again, it depends on the patient, the side effects, and so forth. Really importantly, those who have had now their first depression in later life, they're candidates for at least a year of treatment, sometimes 2 years. But think of it as a recurrent chronic illness in older adults. And here's a really important point. I can't tell you how many patients over the years have said to me, "Oh, I'm better. Thanks so much. Can I lower the dose? Or can I stop the medication?" If you had diabetes and you went on insulin, your blood sugar was now controlled, you wouldn't say now it's time to stop the insulin because you still have diabetes. You still have an underlying biological problem called depression that's likely to recur if you stop the medication, especially in older adults. And I would just say that you can lower the dose, especially if there's side effects. You should lower the dose. But you want to understand why they're asking the question. If it's the idea of being on meds that people don't like, then go with it and maybe lower the dose. But make sure they understand they may relapse at a higher risk and they may be harder to treat when they relapse. When people are older with depression, those coexisting symptoms of anxiety and worry, rumination, etc., generally predict a slower response and a less complete response and a more likelihood of early recurrence after their maintenance treatment. And we don't have a great evidence base for how best to treat coexisting anxiety. What I often do, and what a lot of my colleagues do, is if you've got somebody on an SSRI at adequate doses and adequate duration, we augment with something like mirtazapine if there's comorbid anxiety. What we don't do is augment with benzodiazepines. We try to avoid those as much as possible because of cognitive side effects, gait disturbance, and so forth. When there's coexisting medical illness, cardiovascular disease, diabetes, etc., COPD, this will also moderate the response to long-term treatment. So people with dementia or other medical factors don't respond as well to treatment, unfortunately. We need to do a better job of finding better therapies. And then don't forget that, I know I've said this a lot to not just this group when I spoke before, but other audiences. We know that dementia is a family illness, but depression in later life is also a family illness. And we've got to really pay attention to caregivers. When we treat older adults, we cannot see them by themselves only. We can have plenty of sessions with them alone, but we need that collateral information. And one reason to meet with families is to check in on how they are doing. Because if they're not doing well, whether it's a spouse or an adult child, and they're kind of holding the bag for somebody who's really struggling, if they themselves start to have a hard time, meaning anxiety or cognitive decline, your patient's not going to do as well. So I would say that in every instance of a geriatric older adult mental health encounter, family inclusion, when possible, is, I think, All right. So if we were in a room together, I'd have to stand up and walk around and whatever. But I want to shift now to bipolar disorder. And we're going to talk about depression again. But now we're going to talk about depression when it occurs in people who have had at least one prior episode of mania. When now that diagnosis is no longer unipolar depression, it's bipolar disorder. The diagnostic criteria in older adults with bipolar disorder are no different than in younger adults. But there's so many differences in the clinical features and the approach to treatment. And that's what I want to impress upon. So first, I'm going to tell you about two cases in this talk, like I did in the other one, but these have slides associated with them. So the first is a 76-year-old male that I first met in my first job out of training. And I talk about him to this day because I learned so much from him. So at the time I met him, he was 76. And when I got the history from him and his wife, he was in his 49th year of having symptoms of recurrent bipolar disorder, which for him were about yearly episodes of mania. You know, and for many years, he would go in and out of treatment at the VA. He was a vet. But he was so disabled by his illness and the frequency of his recurrences that he never really worked outside of the house. And his wife actually worked for the VA, and she was the breadwinner of the family, and they raised 5 children. And every time he would get recurrent mania, it was pretty obvious. He would drive erratically. He would get arrested. They would ask him for, you get one phone call, you want to call the Queen of England or the Pope. He would often abuse alcohol when he was manic. And when abusing alcohol and manic, he would become violent, sometimes directed at his family, including his wife. Somehow she stood by his side, which was remarkable to me. So anyway, I see him now. He comes to the mental health center from the VA because his wife is concerned about a recent decompensation, 3 weeks of feeling irritable and not sleeping well and starting to become verbally abusive towards his family. Very characteristic symptoms of his recurrent episodes of hypomania that then quickly become. At the time he was on lithium carbonate. By the way, when he went on lithium for the first time, when it was developed in the 1970s, he started it shortly thereafter. The frequency and severity of his manias did improve overall. I mean, but he stayed on it for years, and he was on 900 milligrams a day with a serum level of 0.6 milliequivalents per liter, and he was starting to show signs of renal insufficiency with an elevation of his creatinine clearance and his creatinine. But what was most notable to me was what the family and the wife and he wasn't even talking about without a lot of prompting, which was that over the past 2 years, he was becoming more and more ADL dependent, and he was having trouble with his memory. So boy, did this raise a lot of questions in my mind. I'm like, okay, you have a guy who gets his first manic episode in his 20s. Now he's in his 70s. What is the typical course of bipolar disorder over the lifespan? And now that they're older, what does it look like? What's the effect of lithium now on an aging brain? Is it neurotoxic? Or is it neuroprotective, as we're now starting? Really importantly is this third point. He was somebody who was older. He was having symptoms of, mood disturbance, cognitive impairment, functional decline, irritability, agitation. How do you tell the difference in someone like this between a recurrent episode of mania, a superimposed episode of delirium from a medical problem, whether it's lithium-induced or infectious or otherwise, or maybe now he's got a second brain disease called dementia, and he's developing behavioral symptoms related to dementia. So, I often will just remind people that when you see patients in different stages of their lives with recurrent mood episodes like this gentleman is presenting with, the differential diagnosis looks different depending on the life stage. So for example, in younger adults, less than 18, the differential diagnosis of mania is this bipolar disorder, or people who present with behavioral disinhibition syndromes, is it bipolar disorder? Is it ADHD? By the way, that ADHD differential continues into adulthood and later life. Then as people reach their adult ages, we often will see people where we can't tell the difference between hypomania, mixed states, or mania, and people with cluster B traits in the old DSM, criteria for borderline personality disorder or narcissistic personality disorder. So cluster B pathology versus, cycling mood disorder. But in older adults, this is the key differential. You see confusion, agitation, mood lability, etc., sleep disturbance, behavioral disinhibition. Is it mania, delirium, or dementia? So all I'm saying is these clinical presentations, especially when you see them in later life, could be driven by a new medical problem. You got to figure that out because it could be life-threatening. So what do we do with this guy? Well, his kidneys were found. And so I called his nephrologist and we decided he needed to get off his lithium or he was heading to dialysis really soon. And even with this, he may be heading to dialysis. Now, there's a lot of literature on this, but when you stop lithium and someone's been on it for years doing well, it runs the risk of relapse at very high rates. You have to be very careful about that. So for him, we put him on divalproex or Depakote. We titrated him to a therapeutic level of in the 80s, 85. And you know, he got a lot better as mania subsided. But what was most notable is his cognitive and functional limitations persisted. And when he was mood stable and behavioral symptoms were stabilized, we had him undergo neuropsychological testing, and he had a diagnosis consistent with Alzheimer's disease. And we started him on donepezil, and we eventually increased the dose. So, oh my goodness, this brought up more questions. Like, so how does somebody with a lifelong history of bipolar disorder, how do they think about their risk of developing cognitive impairment in later life? And does bipolar disorder itself, like we know depression does, schizophrenia may, but what about bipolar disorder? Does having a lifelong history of bipolar disorder increase your risk of developing a neurodegenerative dementia? I'm going to answer that question. I probably won't be able to answer more of the other questions because they're complicated to answer, but this one will answer. And then the third is, what are the evidence-based treatments for mania in older adults? So, by the way, this work with this gentleman and many others in the Manchester Mental Health Center on a number of, I was on a treatment team that was part of a research study. I followed these people for 5 years, and it led to so many of these questions became the areas of research that I eventually pursued. And one of the areas that I worked on was compiling all the world's known literature with my colleague, Susan Lehman, back in when we published this book about 8 or 9 years ago. But we also were working together on this international task force through the International Society for Bipolar Disorders. And we've had multiple publications with this group. It's now called the GAGE-BD group, the Geriatric Bipolar Disorder Group. An international consortium. We've published a number of articles on the world's literature on this. But we can no longer, the point here is we really can't conceptualize OABD or older adult bipolar disorders as just being extrapolating the information we know for a 30-year-old and say, oh, that's what Mr. Jones is going to need when he's 80. Whether it's psychotherapy, pharmacotherapy, psychosocial interventions, whatever, we can't not just rely on extrapolating younger adult data and adjusting it for age. There's no way. It's a different population with different needs. And that's what I want to really highlight in this talk. So we don't have any differences really in the subtypes of bipolar type 1 with one mania in your life. By the way, if you have one mania in your life with no other mania and no other mixed states and no other depression, you still, by the diagnostic criteria in the DSM, you still have bipolar disorder. Some individuals will have an episode of depression and then have only low-grade manias, we call hypomanias, and that's bipolar type 2. And there's, definition criteria for this in the DSM. But what's really important is what I said before, which is early versus late onset. And again, now that I'm the age that I am, nearly 60, older adults greater than 50 are being defined as older adults. I'm sorry about that for those of you who are also over the age of 50, but it's kind of what the literature is looking at right now, less than 50, older than 50. I'm hoping we can up that by 1 or 2 decades in the near future. But the early onset bipolar disorder, again, people in their teens and 20s who get this, is it early onset with later, now they happen to be older or not? That's what we're talking, early versus late onset. So for the early onset, it could be people who had early onset depression and had depression their whole life. And now at 50 or higher, they have their first mania, okay? Or they never had a mood disturbance beforehand, and now they've got mania for the first time. When you see mania for the first time over the age of 50, it's not usually the genetically transmitted, if you will, or genetic at-risk mania, euphoric mania of younger adults. It's often triggered by an underlying medical or neurological problem. We call that what's now in the third bullet point, secondary mania. So it's temporally related to an underlying medical or neurological condition, which I'll talk more about in a minute. Now, only about a quarter of all cases of bipolar disorder in older adults um, uh, sorry, 25% of all cases of bipolar disorder are seen in people over the age of 60. So it is more often seen in younger people. And about 10% of all cases are 70 or above. This data is now, well, it's a couple years old, but I suspect we're going to start seeing this go up because of the demographic changes, that we're going to see more and more of this, because a lot of new onset bipolar disorder in later life is due to dementia or stroke. And we're just going to see more of that with baby boomers aging. So I think those numbers are going to go relatively higher. You can see the lifetime and the point time prevalence, and then the women are still more likely to have this than men, which is interesting. Probably less so in older adults, but it tends to hold throughout the lifespan. But I think it gets more closer to 50-50 in older adults, but it still is more women than men. So what about the neurobiology? So we talked a little bit about the link of depression and dementia before, but there is a link between bipolar disorder and risk of dementia. So the rate of dementia in people who are hospitalized with bipolar disorder, the risk of it goes up and up with every subsequent hospital admission, which makes you wonder, so is it having the illness itself, or is it having the severe decompensations with a mania episode or a depression episode that's really increasing our risk for dementia? And that's probably the latter. We know that there are relationships between brain-derived neurotrophic factor, or BDNF, low levels may be associated with what some people have talked about and have looked into this concept of accelerated aging. In other words, if you follow people with bipolar disorder over their life, you're going to see, and you follow the curves of cognition, you're going to see more cognitive decline sooner and more accelerated than people who age without bipolar disorder. Inflammatory cytokines, mitochondrial dysfunction, which has been my research, oxidative stress, neurotrophins. There's this hypothesis of neuroprogression. Again, what is it biologically that's leading to accelerated cognitive decline with advancing age at a greater rate than you see with people who don't have bipolar disorder? Now, interestingly, there is a relationship between lithium use and neuroprotective factors like reducing amyloid plaque burden. There was this really interesting study, which I don't think I have in the slide deck, but I talked about this for years because I kind of blown away by it. But it was an autopsy study of people who had a history of bipolar disorder. And when the patients died, their brains were autopsied, and they looked. Research question was, what's the effect of lifelong or long-term treatment with lithium on an aging brain in people with bipolar disorder? They found out was that those individuals had more than 6 months of treatment with lithium versus those with less 6 months of treatment with lithium had a much lower rate of amyloid plaque pathology, to suggest that maybe there is this neuroprotective effect of the primary biological hallmark of Alzheimer's disease, which is beta amyloid. So there's animal research suggesting this. There's autopsy human research suggesting this. We've not yet proven this in a clinical trial. Would be very hard to prove in a prospective clinical trial that lithium would lead to a reduction of amyloid plaque. We did a prospective lithium trial for agitation and dementia. We did not get biomarkers of amyloid because they were not easily accessible back then. Now they are with blood tests. I also just want to impress upon you, like I did with the adults, with the older adults with depression, that medical comorbidities are really, really common, especially metabolic syndrome, hypertension, diabetes, cardiovascular disease, vascular. All of these medical comorbidities may contribute to the development of the first episode of mania in later life, may lead to more likely recurrent episodes, may make it harder to treat. We need to pay attention to the medical comorbidities. When you treat older adults and you do geriatrics, you have to learn and be comfortable with medicine. You're not the primary care doctor, but you have to screen for these things, think about these things, know what other medicines people are on. You cannot treat people without taking into consideration the full scope of their medical comorbidities and their medications. And one of the reasons this is important is the cause of death in older adults with bipolar disorder is not just suicide, although that is a cause, 27%, but more likely it's cardiovascular disease, it's stroke and heart attack. Cancer is in there as well. And we know that there's modifiable lifestyle risk factors, including smoking, diet, and substance use. All right, so a couple of clinical considerations. First on the diagnostic end, and then before we finish on the treatment end. Okay. Here's a chart, which again, you guys can have all these slides. Older adult age onset, so 50 or above with first mania versus early onset, mania younger than. Family history, way more common with early onset. The initial presentation of early onset is usually, but not always, mania or hypomania. But the later in life you see the first mania, the later in life you see people with bipolar disorder, the more likely it's that depression came first. This could be people who had depression for years and then got manic, or people where their first episode of a mood disorder in later life is depression. Again, mania is more common in the early onset versus the later onset. There's often a longer latency between the first and second episode in older folks. There's more medical comorbidity, as we talked about. There's more psychiatric comorbidity, interestingly, in younger adults, meaning younger adults with bipolar disorder are more likely to have PTSD and personality disorders and so forth. Cognitive impairment more likely in older adult bipolar disorder, and more likely to use healthcare resources like emergency rooms and hospitals. And there's vastly, vastly less literature in the older adult population. And I talked about this already. The only thing I'll say is that people who develop later life mania, it's often due to a medical problem. So we call it secondary mania because it's secondary to the mania problem, the medical problem. And the genetic risk is much less for those who get mania for the first time in later life. The most heritable, or one of the most heritable of all psychiatric conditions, is mania. As a clinical syndrome, which are so heterogeneous, we know the etiology of our psychiatric syndromes are heterogeneous. Mania is highly genetic, highly genetic. We don't know which genes, but highly passes through families. And younger people with their first episodes and subsequent episodes compared to older people, when they get it secondary to a medical problem, are more likely to respond to lithium. Now, what I want you to think about the secondary mania, you can see this in lots of patient populations. Think of what frontal lobe dysfunction looks like. Disinhibition, poor impulse control, sexual inappropriate behavior, irritability, mood lability, physical aggression, and so forth, even psychosis. These are symptoms of mania when they occur in people with an underlying medical neurological problem, including, most commonly, dementia, even if that dementia is yet to be diagnosed. And it looks like a frontal lobe dysfunction syndrome. It's one of the reasons why we often think of treating people with dementia who present just like this on the slide with anti-manic drugs, because it looks like a mania due to the underlying dementia. And there's evidence for using anti-manic drugs like anticonvulsants and lithium in patients who present like this with dementia. I already talked or alluded to the fact there are many, many causes of secondary mania, endocrine, infectious, interestingly, sleep apnea, vitamin B12 deficiency, and a whole host of primary neurological conditions led by dementia. And there's a whole multiple categories of medications associated with mania. You can see here, I just point out steroids, because in older adults who have COPD and may have a predisposition to mania or a prior history of depression, you give them high-dose steroids for COPD emphysema flare. Watch out for mania. Watch out for psychosis, irritability, poor sleep. More commonly, steroids cause depression, but more noticeably, even the fewer cases of mania are extraordinarily recognizable and challenging. I just want to make sure people understand this concept, because mixed mania is when you have both depression and mania at the same time in the same person. And you may or may not meet all of the syndromal diagnostic criteria in the DSM for full-blown mania and full-blown depression at the same time. But when you see some of those symptoms together, really important to recognize and differentiate, because the treatment of mixed mania or mixed episode, very different than the treatment of unipolar depression. And if you get it wrong, you will make people worse. More severe symptoms, often women more than men present in mixed states. The suicide rate, people feel horrible. There's an inner sense of just agitation. People don't feel well, and they're more likely to harm themselves or even kill themselves. It lasts longer, it's harder to treat, and the substance use abuse rate can be quite high. I talked a lot about this already. The most important thing is get a screening test. And anybody who's older with depression and bipolar disorder, when they are psychiatrically stable or stable-ish, Make sure you have a screening cognitive assessment, including, I would say, the MOCA being the most readily available. I'm not going to get into it now, but there's all sorts of new digital cognitive testing that can really scale and more rapidly assess cognition more effectively. But those are often, costly through startup companies. But I just bet in the next few years we're going to see more standard digital neuropsych evals that are going to be quicker to use and will give you more information on them. Like in depression, if you see cognitive problems in people who are older with mania or depression, you want to think about why. Because some of the treatments we have, we're not using these treatments now, but if you can imagine, all of these things listed on the slide, the medical comorbidities, we can treat medical comorbidities. We can't really treat atrophy and white matter degeneration. We can help regulate dysregulated neurochemistry, dopamine, serotonin, norepinephrine, oxidative stress, inflammation, mitochondrial dysfunction. There are treatments, some are vitamins and nutraceuticals, coenzyme Q10, for example, anti-inflammatories, that may have a role in moderating the worsening cognition in people with bipolar disorder. This area, not well studied, just telling you. But there's a lot of interest in going after targeted treatments because of the prevalence of cognitive problems in people with bipolar disorder in later life. So the answer to one of my questions was, and my colleague, Dr. Diniz from Brazil, helped to answer it, and basically found that if you have a lifelong history of bipolar disorder, you've got about a 4-fold increased risk of dementia in later life. Pretty high. That's the red on the bottom, the sum total of all the studies that are listed. All right. I'm not going to go through a whole assessment protocol. This is, I think, sort of basic, but it's complete because it includes medical assessment, medication assessment, mood and behavioral symptoms, cognitive assessment, including, if needed, neuropsychological testing, medical exam, etc. And I would say get blood work, CBC, complete metabolic panel, B12, folate, TSH. Make sure you're not missing something else that's treatable, especially when you're seeing mania for the first time in later life. And it could be a drug of abuse that's also triggering this as well. I'm not going to go through the number of studies that our GHBD group have been publishing, but I give all the credit in the world to two people, Martha Sujadovic in Cleveland and Lisa Eiler in San Diego, colleagues and friends of mine, who developed this GHBD trial and got funded. And we've been collecting systematic data across populations around the world to learn more about the demographics of bipolar disorder. But this was a published paper last year, basically looking at nearly 1,000 people 50 and above with bipolar disorder, most with type 1s. Most were not highly symptomatic at this random cross-sectional assessment, so they were doing pretty well. They were in their early 60s, a little more female than male, highly educated, only a quarter at this stage of their life were working. 40% were in steady relationships, and their functional measure was moderate, mild-ish impairment. So there's a lot of research that this group has been very active in publishing studies looking at the demographics of older adult bipolar disorder, the treatments. But what's beautiful about this group and this study, it's the first time we've ever had consistent data coming in of cohorts of people with bipolar disorder. Prior to this, it was small, like 20 people from here, 50 from here, 10 from here. Heterogeneous measures were collected, different outcomes were looked at. This is truly an ongoing prospective database data collection study. All right, a couple things about treatment. A lot of what I'm going to show you is drugs that we use in adults for bipolar disorder. What data do we have in older adults? Because my fundamental question when seeing people like I presented was, now this guy's 76, what's the response to lithium or Depakote or risperidone in older adults compared to younger adults? Do we even know? And the answer was, we didn't know. And guess what? We still don't know, with one exception, which is lithium and Depakote, which I'll tell you in a minute. These are the drugs that have been approved by the FDA. This is not age. It's all 18 and above. So they don't differentiate like with kids. They differentiate less than 18, the FDA. They don't differentiate older adults for the most part. So the drugs on the left, longest column, we have a lot of antiemetic drugs. The drugs on the right, we have some, maybe 3/4 as many. And thankfully, there are a few more now in the middle with bipolar depression. But this remains, in my mind, the hardest to treat condition. When people with bipolar disorder get depressed, they don't respond well to treatment. And the treatments are very different. Like unipolar depression, you don't use antipsychotics as first-line treatment. You use them as augmentation strategies. Here, they're used as first-line treatment, and they are effective. And most of the data is in post hoc secondary analyses of large data sets, not prospective trials. So I want to present this case because the woman I saw a number of years ago that also taught me a ton about bipolar disorder in older adults. She was 75. She had had her first manic episode in her 30s. She was treated at McLean. She was on lithium for 30 plus years. She had become increasingly depressed, lethargic, with poor attention, memory loss, and lack of motivation just in the last 3 weeks. Really healthy. She had osteoarthritis, hypothyroidism, and she was on lithium 900 milligrams a day. Her attention was poor. When I asked her about her memory, she's like, I don't feel sad or guilty, or I'm not crying, but I just don't feel like doing anything. Apathetic. But when I did a brief neurological exam and I did finger to nose pointing, and she had a little intention tremor. So I got a lithium level, it's 0.9. If you look up in all the books, therapeutic lithium levels say 0.6 to 1.2. I'm like, oh, it's therapeutic. But I started to think, wait, she's 75, she's apathetic, and she has signs of lithium neurotoxicity, which is intention tremor. So I cut her dose in half, and she miraculously got better. It wasn't depression. It was lithium neurotoxicity. And that led to some investigations of what's different in older adults, where the lithium levels are not the only way to make a decision about dose. Because if you just go by a level, you likely will overshoot. You could undershoot, but you may likely overshoot. You really got to look at the full picture in the person. And what we learned was the relationship between brain lithium levels, which we can measure with an imaging modality called MR spectroscopy, and the blood levels varied in a different way depending on they were young adults or older adults. There was a clear relationship with younger adults. The relationship is all over the place in older adults, likely due to changes in the blood-brain barrier. Anyway, lithium best studied in older adults with bipolar disorder. There is one primary, I'll tell you, the Jerry Beatty trial looked at lithium and Depakote head to head. It works for mania, bipolar depression, probably works in mixed states as well. It's got a narrow therapeutic window. Got to be very careful about dosing with toxicity, neurotoxicity, but longer term renal insufficiency, hypothyroidism. Jerry Beatty was the first randomized control trial, and to this day, 2024, the only existing randomized control trial of people 60 and above with mania. Everything else, all those other drugs on the left-hand side of that other slide that I showed you, were studied in populations where the mean age was 40. So we don't have a lot of good geriatric mania data, except for this study, and it was just lithium versus Depakote. Risperidone was added on when there was refractory symptoms after 3 weeks. The NIMH funded, my colleague and mentor, Bob Young at Cornell, was the PI. The outcomes are here. Green is Depakote, and the orange diamond is lithium. And change from baseline, lower is better, so greater change. And what you can see is, and this is 60 days out, so what is that, 9 weeks? This is a 9-week trial. 9-week trial showed that lithium did better than Depakote after 9 weeks. Depakote did well too, but there was definitely a difference statistically between lithium and Depakote. So the greater reduction there, which is interesting. These were inpatients and outpatients, many years to do. So just quickly, I want to get to the next few so we have plenty of time for discussion. But lithium, got to be careful because that narrow therapeutic index of the cognitive side effects, delirium, or just mental slowing, people just don't feel as sharp. And older adults whose brain is maybe also having neurodegenerative dementia, we have to be careful. Polyuria, polydipsia, edema, hypothyroidism. Now, these are the predictors of poor lithium responders. And basically, I'll just describe it to you. Somebody who's older when they get their first episode, whose first episode is depressed or mixed and not euphoric, who's had more than 3 episodes, who also uses drugs or alcohol, who doesn't have a family history, who has a known underlying neurological problem, or maybe 4 or more cycles a year. These are the people who don't do as well with lithium. They'll do better with the anticonvulsants like divalproex. There have been 5 uncontrolled studies and that one randomized controlled trial with divalproex. It works best for mania or dysphoric mania. Doesn't really work for bipolar depression. You can see the side effects here, including elevations in liver function tests. Lamotrigine, I did a lot of research with lamotrigine because I was interested in its effects on energy metabolism in the brain and oxidative stress. But it also, from a clinical standpoint, seems to have antidepressant effects. But it was approved by the FDA not as an antidepressant for bipolar depression. It was approved for preventing recurrent episodes of mania and depression. That's true for young and older adults. Martha Sajadovich published a bunch of secondary analyses of pivotal maintenance trials that led to its approval by the FDA for bipolar maintenance treatment. And there are nearly 100 subjects, 240 milligrams a day. It was more effective in recurrent episodes compared to placebo. It did better. We think this does better in bipolar depression than in mania, and that's almost certainly the case. And the response and remission rates in open label treatment in this one study were really good. There are case reports, but very little data with topiramate, gabapentin, Keppra, etc. Again, secondary mania, divalproex first, maybe lamotrigine if it's bipolar depression or mixed states. You can see the starting doses in the serum levels. Now remember, like with lithium, older adults with Depakote can get tremor and ataxia. Those are problems. They could get delirious from high levels of ammonia. They can get platelet dysfunction, etc. And here are some of the side effects I just mentioned. Plasma concentrations. Just a couple things about antipsychotics. There's no randomized controlled trial data that I'm aware of in older adults yet for mania with atypicals, but there's a lot of research on atypicals in older adults with dementia. So we know a lot about the side effect profile through the dementia population, not the older adult bipolar disorder population. But again, there's post hoc analyses of data with clozapine, olanzapine, et cetera. You can see here that may benefit geriatric bipolar disorder. We did some studies with lorazepam for bipolar depression and for maintenance treatment of recurrent depression. And that's listed here, the third study there, the post hoc analysis. Our results for typing also have these post hoc analysis. Safety issues. You give somebody an atypical, they're older with bipolar disorder. You worry about 3 things in the early days: orthostasis, sedation, gait disturbance. But in the longer days, we know with dementia at least, there's a risk of mortality and stroke in some of these drugs. But is the mortality warning there for bipolar disorder? It's not there, but does it cause mortality in bipolar disorder? We don't know for sure, but there is some suggestion based on this VA database study that there might be slightly higher mortality rates when using certain antipsychotics versus others, like risperidone versus quetiapine. But definitely divalproex, mood-stabilizing anticonvulsant, seems to have a lower propensity for death in 6 months than the atypical antipsychotic. The tardive dyskinesia rates are higher in people with who are older than in younger people. This is the STEP-BV trial. Okay, don't forget non-pharmacological interventions work. I was involved in the HOPE study when I was right out of training, ECI, MASS-PD, et cetera. But these are different interventions that help to improve psychosocial, clinical symptom, and even cognitive outcomes through engagement and things like that in people who are older with bipolar. ECT also works in older adults with bipolar depression. When you have bipolar disorder with catatonia or psychosis, it's particularly effective. And we now have some data on the efficacy and safety of the right unilateral brief pulse, ultra brief pulse ECT, which appears to be more cognitively speaking. Again, there's some data with RTMS now, DDS, MST, TDCS, FEAST. There's a lot of experimentation going on in neuromodulation. I wouldn't say any of these are standard of care. I'm just mentioning there's research going on. So if you've got somebody with mania or mixed states, the data supports generally using either lithium or divalproex, depending on tolerability, safety, preference, etc. Partial responders, there is evidence from the Jerry Beatty trial to add risperidone. Probably could also add other atypicals. For treatment-resistant episodes, ECT or clozapine may be helpful. But we don't have a lot of guidance on how long do we treat and when do we stop and when do we augment. Like we have more guidance, way more guidance, as I said before, in unipolar depression. For bipolar depression in older adults, monotherapy with lithium or even lamotrigine, even though it's not FDA approved, may work. Or if they have persisting depression despite mood stabilizers, adding an atypical antipsychotic or even a cautious addition of an antidepressant like SSRIs or bupropion may be needed and may be effective. And again, we talked about ECT for more severe patients. Don't forget to manage comorbidities, as we talked about. And just a couple things on future research. There's so much we need to learn here. The Gauge BD group is doing most of this work right now. And what we're doing is we're including populations that are not just older adults who are otherwise medically healthy. We're actually including people with medical comorbidities. We need to include people with cognitive impairment too, because of its prevalence and its high risk, as well as the folks with cerebrovascular comorbidities. Not only should we be tracking symptomatic outcomes in any bipolar disorder study in older adults, but older adults with mood disorders of all kinds, we have to be tracking functional measures, quality of life, and cognition, and understand those factors that are associated with appearance. So in summary, in the bipolar talk, when you see older adults with confusion, agitation, psychosis, disinhibition, the key differential is dementia with behavioral symptoms, delirium, or mania. Make sure you understand if this is early versus late onset and whether it's primary or secondary mania. Although the prospective randomized controlled trial data in older adults with bipolar disorder is limited, there's a fair amount of post hoc analyses and retrospective chart reviews for safety and efficacy with atypical antipsychotics, lithium, and anticonvulsants. Don't forget about managing medical comorbidities and always use psychosocial interventions in addition to pharmacological interventions. So thank you, guys. That was probably the longest I've talked in a long time. Dr. Katzman, lead us through some Q&A. I see a lot.
And that was like opus. And I think everybody out there is just so happy to learn from you. And so let me say first that we will be sending slides to those that want them. So, and thank you for making those available, Dr. Forster. That's great. So there's quite a few Q&A and not so much time to get to them, but let me start with some questions from Jeffrey Harper, who has a general question about addressing the challenge of differentially diagnosing or evaluating memory impairment in patients who have early onset dementia and are also depressed and sad and tearful and apathetic. And how do we know how much cognitive impairment is related to significant major depression and how much is attributed to dementia?
So great question. The way I think about this is we take we do our usual assessment to try to understand causes of symptoms, right? And then in terms of treatment, we treat symptoms. We can treat depression. We can treat anxiety. We may or may not know the full etiology. We want to make sure we're not missing a medical cause of those symptoms. It may be depression, anxiety symptoms due to UTI, depending on, time of onset. So if you've got somebody and you're not sure, is it depression or dementia, but they definitely have depression, you treat that depression. And as they get better, then you'll have a better sense of what their baseline cognitive functioning is. But what I want to throw into this is something I couldn't have said a year ago, which is that the biomarkers for Alzheimer's disease are rapidly advancing. You're not going to go out and get an amyloid PET scan on someone like you just described because it's expensive and it won't be paid for. Although if they have MCI and early Alzheimer's disease, they might be a candidate for the new therapeutics. You're not going to get an LP to look for amyloid, but if you've got a $150 or $200 blood test called phospho-tau 217, p-tau 217, that accurately represents amyloid plaque burden in the brain. And again, there are many other etiologies of dementia than amyloid pathology. But with that test, you're now going to have a biomarker that's going to give you a clue about whether their cognitive impairment may not just be from depression, but it may also be from a neurodegenerative illness. What I want to warn people about is as these biomarkers become available in clinical practice and paid for, don't stop doing a comprehensive assessment because at the end of the day, it's still just a biomarker. We still treat human beings, not blood tests. And so I want to make sure that, again, your patient that you described, treat depression, get a great collateral history from family about onset of both cognitive challenges, depression, what came first. And when their baseline mood symptoms are better, assess their cognitive functioning And if it seems like they meet criteria for a neurocognitive disorder, then treat them like that, knowing their depression may still relapse. When people present with both, you may get their depression better and their cognition may also improve. But more often than not, within the next 5 years, most of those people will have a neurodegenerative illness, symptomatic at that point. And what you're seeing in a patient like you just described is the tip of the iceberg of the dementia presenting as depression. We see a lot of people with dementia whose first signs were mood anxiety. But it's a really great question, very common problem.
Great. Dr. Gerber out there is asking, saying traditional teaching is that augmentation should be reserved for patients with a partial response. Are you recommending augmentation in the absence of a response signal?
No, I'm not, because the one trial that tried to address this, Eric Lenz's trial, which was published last year in New England Journal, that study I showed you was people who had been treated and had a partial response. So for people, first of all, I wouldn't start de novo 2 drugs. Okay, definitely don't do that. Less is more. Polypharmacy not good in older adults for the most part. If people have no response whatsoever, don't add a second drug. But make sure you've done adequate dose and duration. And in older adults, it may not be 6 weeks, it may be 12 weeks. If there's nothing at 6 weeks, then I would switch. If there's something at 6 weeks, I would add, or I would just wait. The adding may be better than waiting based on Eric's study, but that hasn't been replicated. So I think it's going to really depend. But I wouldn't do 2 drugs at once, and I wouldn't augment someone who has no response.
Richard, can you say something about the role of loneliness in this population and its contribution to depression, and the degree to which you or the clinics you're involved with or others are screening for that or talking about that, and kind of how do you talk to patients about that?
I have a colleague at the Brigham, her name's Nancy Donovan, and she was a general psychiatrist for decades, came to me many years ago and said, I really want to work with older adults. She did a fellowship in her mid-career and became a really amazing geriatric psychiatrist. And she started doing research. And she said to me, and this is a decade before the pandemic, she goes, I think loneliness is a huge problem in older adults, and I think it's a risk factor for dementia. Mm-hmm. I don't know where she got this idea. I'd never heard it before. And now everyone's talking about it. Mm-hmm. She's done some amazing research. Nancy Donovan's done work in this, so you can take a look at her stuff. Looking at the neurobiology of Alzheimer's disease in people with loneliness, or loneliness in people who have known plaque-entangled pathology and other forms of dementia. There does seem to be a relationship, maybe bidirectional. I don't think we have a great screening tool that's used systematically in our clinical settings. I think that is an opportunity. It's definitely it's an unmet need. And so what's hard is, and I think there are people out there who are now specializing in this area, but what's hard is, just like it's hard to differentiate apathy from depression, it's hard to differentiate loneliness from depression. Are people feeling lonely because they're depressed, or are they just lonely? And I think people are now recognizing loneliness is a thing unto itself, just like apathy is a syndrome unto itself. We don't have a great definition for it yet. We don't have great screening tools for it yet. I would ask questions about whether people feel alone as opposed to feeling sad and down in the dumps and depressed and guilty and ruminating. There are plenty of people who are alone but don't feel alone. They don't feel lonely. It is different. It's the feeling of being lonely that's the worrisome thing. And then what do we do, right? So does psychotherapy work? Does getting people out in activities? How do you get somebody who is feeling lonely to engage with other people? Is there some apathy there? This area to me is really interesting, really important, and we are only at the very beginning of really understanding what to do.
Great. So many questions in here. Jeffrey Harper asked another question here. He says, have you seen cases of sudden, seemingly capricious onset of symptoms of depression and anxiety, as well as rapid and almost quantum-like decline in cognitive functioning? He describes a 92-year-old widowed white Caucasian female who was taking not one prescription medication. She was exercising 3 times a week, playing bridge, reading a lot, running a large fund. And then one morning she woke up beset with symptoms of depression and anxiety, including agoraphobia, a fear of encountering people in her senior residence, despite no unfortunate experience in her social life. Her memory suddenly and significantly declined. Lexapro and Ativan failed to have an impact, and the trial of sertraline had similarly failed. Her mood remains depressed, and she has repeatedly says she wants to die with no plan, is considered a suicidal risk, and tests reveal a history of strokes, TIAs, with no visible clinical presentation. So does that kind of ring bells for you in terms of that presentation?
Yeah, I would say that last sentence is really important, and I would want to know more about what diagnostic tests were done. I would suspect that if there are TIAs, but if you have a history of that, is it a really TIA or was it a stroke? And it says history of stroke. So what I would say is most likely there was an acute cerebrovascular event that led to this. And it may not have led to motor function abnormalities or sensory abnormalities, or even delirium. But if you see a rapid onset of any mental health syndrome or cognitive decline in older adults, it is a medical or neurological problem or a medication side effect or a drug of abuse problem. And it's not a primary idiopathic psychiatric syndrome like we see in the 30-year-olds who's healthy. And it may be hard to pick it up, but I suspect if she had a history of microvascular ischemic disease and possibly strokes, and there's evidence of that by history and by imaging, she probably had another event. And for whatever reason, because of location or size, or because of underlying neurodegenerative illness like Alzheimer's disease, which you can't see on an MRI, and she had no baseline testing, and she was probably a super ager, and now all of a sudden something happened that changed that delicate balance. The one thing I'll say is, people who start very high in terms of intellectual functioning, cognitive functioning, and they have what we call a lot of cognitive reserve. Those are the people who rapidly decline. And it doesn't take much. Like something finally, it's like been gradually neurodegenerating brain from vascular or Alzheimer's pathology, let's say. And now one thing happens, like a stroke in the right place, and boom. You've got a psychiatric syndrome that looks like this, and you've got what looks like rapid cognitive decline. More often than not, there's a medical comorbidity like infection, hypoxia, diabetes gone awry, or medication side effect. But in this case, the way it's described, I would bet it's a cerebrovascular issue.
Great. Thank you. There's a few questions about specific medications. Here's one. Do highly anticholinergic drugs increase the risk of dementia?
There's been a controversial series of papers in the last few years that have looked at drug classes people take over years and subsequent risk of dementia. Remember, these are not prospective trials. These are epidemiological studies in large databases. The first that came out that got a lot of attention and may have been debunked is the benzo risk for subsequent development of dementia. And this is a similar question around anticholinergics. I don't know how to answer the question, but this is how I think about it, because I don't think we know. But I would say that anticholinergic drugs cause cholinergic deficiency because of blockade of cholinergic neurotransmission, which we know is required for normal learning and attention and memory in any age. And when you've got an aging brain, there is normal loss of cholinergic neurotransmission. And by giving people anticholinergic drugs, you're speeding up that process. So you're not causing dementia, but you're causing symptomatic cognitive impairment by the use of these drugs. What I couldn't tell you is in any given person, you remove the offending agent, do they go back to baseline or not? I don't know. I think of anticholinergics as being neurotoxic to the brain. That's why they're on the Beers criteria list as no-nos in older adults. Scour that med list and the over-counter list for anything with anticholinergic toxicity, and when possible, reduce the dose or remove it. Again, when possible, meaning from a medical standpoint. There's no good reason for older adults to be on long-term use of benzos, anticholinergic drugs, or opiate analgesics. If older adults were on none of those three classes of drugs ever, we probably have less than half of the referrals that we get in geriatric psychiatry.
Yeah, wow. All right, Dr. Forster, we're at time. Their questions keep rolling in, so and so do comments saying thank you for this outstanding presentation, and I want to thank you too. There's so much information here, and again, we'll make the slides available to anybody who's participated. And this really was an inspiring presentation with so much information. Thank you to everyone who joined us today. As a reminder, people who want to get continuing education credits, please complete the evaluation survey that will automatically show in the browser when we end this webinar. And again, Dr. Forster, it was great spending this time with you again. Thank you for returning to be with us. And thank you. Thank you, everybody, for being here. And hopefully we will see you again on November 13th.
Thanks, everybody. My pleasure.